And the next session is of a great application of a paramount importance and a very prolific speaker, Dr.O.P.Yadava. I'll request him to come on the dais. And this is the oration in the name of K.K. Malhotra Memorial Oration. And the topic is going to cover is minimal invasive CABG. Is it really a hope or a hype? Poonam Malhotra, if she is in the audience, I'll request her to speak a few words about this oration, because this is a very, very important oration. And I'll request Naveen, Dr. S.K. Parashar, Dr. Ravi Kasliwal, and Vijay Lakshmi to please join me and bestow upon this oration to none other than our own Dr. O.P.Yadava. Poonam, would you like to speak a few words, please? Come here. Poonam, you can come here.
It is indeed a great honor for a daughter to speak about her father. My father was probably one of the best human beings. I think every child thinks like that about the father or the mother. But in terms of a larger-than-life image, Dr. K.K. Malhotra had more. And today with Dr. Nanda, Dr. H.K. Chopra, Dr. Parashar, Dr. Vijay Lakshmi, Dr. Kasliwal, and Dr. O.P.Yadava, great guys, all of them big giants in their own fields, standing together to honor posthumously a big man like him. I feel all his works that he did in a very small, humble, charitable way have come of age. It is really an honor to have Dr. O.P.Yadava. We do so much of minimally invasive surgery today everywhere, and for an orator like Dr. O.P.Yadava to speak on it, I think it's a big blessing. Thank you, sir, for being here.
I just like to speak only one line about Dr. K.K. Malhotra. We have a long association. Dr. Khalula is sitting here and looking at me. Why he is not telling me he was a good friend? Very, very good friend. He was the HOD of RML Hospital. Tremendous contribution in community service. He will go to every camp possible. At that age of 75 or 76, very humble person, simple. It is very difficult to be simple, but it is very easy to be complicated. He was a person full of simplicity. And I think this oration is bestowed upon none other than a very powerful surgeon speaker. Surgeon speaker, not surgeon. Surgeon speaker is Dr. O.P.Yadava. I think I'll request Poonam, Naveen Sinanda, Vijay Lakshmi, and Dr. Parashar to please bestow upon this medallion. Ravi, please join and bestow upon none other than, my God, so many people. Poonam, please give this token of appreciation. Token. Dr. Parashar, please.
I was worried, sir, if the news is going to be tightened.
Thank you very much. With this, I'll request Dr. O.P.Yadava to give this oration, please.
Well, ladies and gentlemen, it's such an honor to be delivering this oration today. Unfortunately, we lost Dr. K.K. Malhotra 4 years back, but we feel his presence through the legacy that he has left behind. Mrs. Malhotra, unfortunately, because of a fracture, couldn't be here. We miss her, but he has left behind 4 lovely daughters, one of them here, Poonam, and for those who don't know, 4 that he adopted of his brother, and that speaks volume. He brought up 8 children. He was the first MD medicine from the Wellington or the RML hospital in Delhi, and subsequently joined the forces, served during the Indo-China War. He headed the Department of Medicine at RML Hospital and set up the coronary care unit in '81, and not to be given to accolades and honors, he actually refused Padma Shri when it was announced for him in 1988. And a multifaceted man, not just a doctor, a human being, he was an author. He was a philanthropist. He started a clinic, a school, a path lab, all on charitable basis. And he believed, to quote his own words, self-praise is no commendation and service before self. His main aim was to uplift the downtrodden, and he started the Bal Vikas Kendra at Noida under the Malhotra Trust Foundation, which runs even today. And he ran a clinic at his own residence right till the last day of his existence in this world. Compliments to the family who brought out this book in his honor, and a copy is available for those who want with the JP for free distribution. So, ladies and gentlemen, with these words, I bow my head in reverence, and I hope Professor Malhotra, sitting in the heavens, partakes of the proceedings this afternoon, and we have his blessings. Minimally invasive surgery, or CABG, hope or hype. Typical Dr. H.K. Chopra, a thought-provoking and a provocative topic, and very relevant today. Now, it's used colloquially and is very often used in generic sense. But minimally invasive CABG is a proper noun and has got three constituents. It has to be multivessel bypass, it has to be off-pump bypass performed through a thoracotomy. But we tend to use it for any procedure which reduces the invasiveness of CABG. Now, the invasiveness of the CABG comes through one, cardiopulmonary bypass, because it produces a whole body systemic inflammatory response with activation of all kinds of nasty molecules, and no matter what we do in commercial setup, 0.1 and 0.2% mortality, the world over the mortality stands of bypass surgery. If you look at the STS national database, 1 to 2%, and a morbidity of 20 to 30%. Second problem is that of sternotomy. It is associated with sternal instability, with respiratory dysfunction, prolonged pain, and delayed return to work. And thirdly, we rip open the entire body, incisions on the hand, on the chest, on the legs. So length of incision also contribute to invasiveness. Now, minimally invasive surgery, as far as heart is concerned, has been a laggard, because if you look at abdominal surgery, everything is ectomy. You do an appendicectomy, you do a cholecystectomy, but you don't have a cardiectomy. So most of the heart surgeries are constructive surgeries, not destructive, and then motion of the heart is a big problem. And the biggest impetus for this came when the angioplasty was introduced. Until that time, the surgeons, having introduced bypass in 1960s, sat on their haunches, making no improvement, thought they have achieved everything. But when the cardiologists challenged the surgeons and surgeons came to the bottom of the reference chain, then they realized that we have to do something to reduce the invasiveness of CABG, and that's how the minimally invasive surgery came into being, more as a response to the kick on the haunches given by the cardiologists. And they started looking for alternative techniques. They developed new technologies in terms of perfusion cannulae, special instruments, hybrid theaters, and a bypass surgery. From a typical heart-lung machine, resting heart surgery, it became an off-pump surgery, it became a non-sternotomy surgery, and then robotics were introduced. All kinds of names and sobriquets were given, TCAB, ENDOCAB, and lately, 2015, another one, not MECUS, it is called ultra-minimally invasive, where robotic surgery is performed on an awake patient using epidural anesthesia and even small subxiphoid incisions, which have been given exciting name as transabdominal CABG, have been launched. And certain new developments like facilitated approaches to vascular anastomosis. Today we have staplers like abdominal surgery, and you can just staple an anastomosis. You have coupling devices. Just like the two railway bogies are attached with magnets, similarly you've got magnets available. One magnet you put on the conduit, another magnet onto the coronary artery, you bring it together and zup, they go, they unite, and the anastomosis is done. So very exciting times we are looking at, and these anastomotic devices have been proven. If you look at the graft patency rate, not the same as hand-sewn anastomosis, but getting there. They are into 90% at 3 months. Also, endoscopic conduit harvesting with all the perceived advantages have come up, but then they have all disadvantages also. You can produce thermal injury and mechanical injury, so patency is an issue, learning curves are long, and then let us not forget the costly equipment required for that. The balance is equal. As many series which talk of the goodness of endoscopic harvesting, there are as many also available which say, no, their long-term results are not good and they should not be taken up, including a 2015 publication. Now, if you look at this, along the x-axis you have the invasiveness, along the y the efficacy. The pump surgery performed to sternotomy is very high on efficacy, but it is also very high on invasiveness. When Meeker's surgery was introduced, invasiveness certainly came down, but so did the efficacy. So the goal is that we should keep the invasiveness down, but the efficacy must go up, and that's where the current all efforts are being made at. As the length of the incisions were reduced, the operating time got increased, training challenges got increased, and the costs, as I told you, went up. Now, what is good about these surgeries? They lead to sternal sparing, so sternum remains stable. They have a quick convalescence. They have less tissue trauma, less pain, less complications related to the heart-lung machine, and hopefully less operative morbidity or mortality. But then every coin has a flip side, and for every good, there is evil hidden in the good, and therefore there are issues. As I told, they are technically demanding. They take long time with a long learning curve. For anesthetists, they are a big challenge because you have to do a single lung anesthesia for these patients, so one lung has to be collapsed, and then there are problems with creating an anastomosis from a limited vision, and therefore the patency rates have been debated, and the early angiographic occlusion rate have been reported as high as 10%. And that's why Bonatti et al. Said that it is very important that we have to validate the anastomosis by doing intraoperative angiography. Now, there have been a lot of studies lately in 2014 and 15 which are talking of patency rate at about 90% and upwards at 5 years, but they categorically give this caveat which we don't impress, and that is safe procedure, but in selected patients, unquote, is what Berumoglu writes in his own publication in 2014. And a landmark publication by McGinn. In fact, this procedure is also known as the McGinn's procedure. What does he say? It's a new technique in need of external validation. Its results may not be generalizable to all centers. And if you look at direct head-to-head comparison, look at graft patency, morbidity and mortality, no difference. So hard endpoints, no difference. But soft endpoints, decrease in ventilation time, less drainage, they go in more in favor of minimally invasive surgery. Similarly, Raja et al., just 2 weeks back, a publication 2015, barring increased surgical site infection with sternotomy, no benefit of minimally invasive surgery. NG et al., in fact, challenged that even your wound complication rates are no less. They say anterior thoracotomy wound complications are not insignificant and may be underestimated in minimally invasive option, unquote. You look at STET trial, that goes the complete 360-degree turn. In fact, in the STET trial published in JTCVS, minimally invasive surgery scored much less than the pump surgery performed through a sternotomy. They had longer operation, they had more incomplete revascularization, they had increased need for analgesia, increased costs, and on all fronts, it showed inferiority to the pump surgery, to the sternotomy surgery. Now, if you look at safety also, look at the Lepere study. If you have to convert a patient for hemodynamic instability or electrical instability, then you have to do a sternotomy. So 7% of patient needed a sternotomy, and roughly 1/5 of the patient, they had to be put on heart-lung machine. And this conversion may be as high early in the learning curve as 50% according to Taggart et al. In November 2014, a 6 months back publication. Even if you look at long-term results, very, very satisfactory, but no way superior to the standard surgery performed through sternotomy. Robotics have been also introduced. They do look very exciting, look very jazzy and glamorous, but what are the advantages? Reduction of tremors, small incision, quick convalescence. Again, I repeat, where are we talking of survival and mortality benefit? None at all, not even in an anecdotal single study till August 2015, there has been in the world literature where hard endpoint benefits have been showed. You look at Helkos et al. Publication, graft revision intraoperative was required in almost 10% of patients. So a graft validation will have to be done. And another publication of July 2015, very soft endpoints, robotic surgery was better. It reduced the ventilation time, reduced blood transfusion, but no benefit in mortality statistics. So Taggart, Professor Taggart is a big name from Oxford. What does he have to say? A clear benefit has not been demonstrated. Questions related to graft patency and long-term results persist, and surgical robotic and CABG surgery does not seem likely in the near future. Now, there are advances. Developments are going on. Today, we are talking of tactile feedback and robotic wrists with 7 degrees of movement. So that are going to behave like a human wrist. We have smaller instruments. We have now the current generation robotics coming with a 4th arm called the telemanipulator arm. Now, they may have improved the result, but as it stands today, we have only demonstrated feasibility of these surgeries, but the learning curves and costs are extremely high, and costs can't be ignored. You know, science and society cannot be separated. I mean, that is our true India. It's a country of, all kinds of calamities. Now, how many lovey-dovey families are reduced to total penury offering these procedures? And here we are talking of a procedure 3 times more costlier with benefits not conclusively proven till date in any series, not in the hands of the beginners, but even in the hands of the stalwarts. Also, it is not applicable to all. If a patient has any hemodynamic instability, if he has any chest wall deformity, if he has got severe pulmonary disease, morbid obesity, all kinds of things, and you need to have a specific anatomy. That is, you should have a left main with a normal RCA or a triple vessel disease with a large PDA, then only we can do this surgery. If a patient is a high-risk case for sternotomy, someone who has got an osteoporotic sternum, long-term steroid use, severe COPD, if you avoid a sternotomy in these patients, most welcome, do a minimally invasive surgery, but is it available for an average bourgeois class man on the roads? The answer is a categorical no. It's a technology which is still evolving and has not still found its ground. So, what do we say to yes or no? Not yet in all patients, and likely not yet for all surgeons as it stands today. And if we do use it across the board for every single patient, for some other ulterior reason, all we are going to do is bring pain to the patient and to the society. So if I were to conclude and take a final accounting, is it feasible? A big yes, yes. Is it applicable to all patients? Certainly no. Certain limited subset of patients it is applicable. Efficacy, soft endpoints, yes. Hard endpoints, no. Safety, yes. Safe to an extent if done in competent hand. Is it been adopted the world over? The answer is no. It is still a specialty available in few hands. Is it freely available? It is not. Is it cost effective? Answer a categorical big no. Long learning curve, and we need intraoperative graft evaluation. Without intraoperative graft evaluation, those centers which are practicing this are against the guidelines. We cannot do it unless we validate the patency of this graft. So it's slowly but surely catching up. I grant that. But it needs further research, and till such research comes in, it should be treated as a niche specialty to be done by a few centers. And whichever patient needs this kind of a surgery must be referred to that center. But unfortunately, that's not happening. What should be the ideal? Ideal should be, why do we need minimally invasive surgery? We should negate if the patient is old or frail or with increased comorbidities, only then we should do it. Or we should do it if we can improve the morbidity and mortality. Or if we are doing better resource utilization, we can do 20 surgeries rather than 2 in a theater, and if we can do it at a low cost. But the reality is what? The reality is this. I have not changed, ladies and gentlemen, one alphabet of this. This is the actual reproduction of a multinational company selling minimally invasive instruments. And look at what their reason for selling. Their official document says, it will increase referrals from cardiologists. It is a marketing opportunity for the practice. It will increase your caseload in a competitive market. Those terminologies which will hurt the conscience of any sensible doctor. These are not the words which we are talking of. Patients are not commodities. Are those the reasons we are doing minimally invasive surgery? Well, ladies and gentlemen, as it stands today, it is a duckling. It has come to life. But it's an ugly duckling, needs more refinement before it becomes a swan and is there for consumption of one and all. Thanks a lot.
Thank you, Dr. Yadav. You showed in a very elucid presentation that minimally invasive surgery is a hope for the future, but it is hyped by the industry. And we as doctors should be able to select our patients in whom we need to use it. Thank you all for patient listening, and particularly thank the organizers for this oration and Dr. Yadav for giving such a wonderful oration. Thank you.